A great day for us because it's our 2-year anniversary for Right Care Initiative in the Capital Region. So, thank you. And I wanted, first, most of all, to thank Hattie Hanley and the team, our executive team that meets together on a really weekly basis to try to plan our work that we do around the Capital Region Right Care Initiative. And you know, it's really been a great experience for me working with Patty and the team. And I just wanted to thank you as well, and Adam, thank you for all you do. I wanted first of all to ask Diane Littlefield if she would be willing to come up and say a little bit, because one of our big and one of our more important partners, of course, is Sierra Health Foundation and Diane and all the great support that we've had to carry this on. So thank you, Diane, as well.
Good morning, and thank you, Dr. Ravelo. I just want to say 3 things, and one is just I want to thank you all, and thank Patty and the leadership of the team. It's been 2 years. I didn't realize it's gone by so fast. We have really appreciated this partnership. There really aren't that many venues in the community that have been so successful at bringing together public health, healthcare services, the healthcare systems, and community together to work together to really address chronic disease in the region. I think you've had a tremendous success. And I just want to, first of all, just thank you for allowing us to be a partner in this effort. And second is, I hope we continue, because I think the momentum is really, really building. And I think a lot of groups look to your group in terms of what you've done right and really trying to make inroads in this area, because it hasn't been easy. It's been challenging. And so, and third is welcome to Sierra Health Foundation. I think you all know us. This is our conference and convening program and policy program part of the foundation. And so, you know, we look forward to partnering with you in many different ways, and where we can be of service. And just so welcome. Thanks so much.
Yeah, we really highly value Sierra Health Foundation's support and all the great work that Sierra Health is doing to address some of these very same issues, not just with this program, but with other programs that are getting put together with a partnership that's being developed, and with you who are here today, critically important. So thank you as well for being here with us and supporting us in this past 2 years. We hope we're going to continue to have many more years of this kind of support and this kind of work. And hopefully some really important impacts in terms of cardiovascular risk reduction for the Sacramento and the Capital Region. So what I'd like to do, if you don't mind, is take the opportunity to have you introduce yourself very briefly, just kind of your name and who you represent, if you don't mind. So if we can start, first if you can, Gil.
Okay. I'm Gil Simon. I'm the medical director of Sac Family Medical Clinics. I was asked to just give an update on our blood pressure control.
Microphone's on. It's on.
Okay. I don't think so.
They're not on. Okay, let me see this little one.
Well,
Do you want to step up here, Gil?
yeah. Okay.
So thanks to HSAG's information services that they provide for us, we've learned that our newest hypertension control rate is now up to 68% from 64%. So each month we're getting closer to our target of 80%. We've also learned that roughly 1/8 of all of our new patients coming in through Obamacare are uncontrolled hypertensive. And so our goal is to get them under control faster than they're coming in, otherwise our rates will go down. So, but we wouldn't know this without having the informatics of HSAG, and that's what we're grateful for.
Debbie Nixon, I'm with Health Services Advisory Group.
Darrell Flynn, Sacramento Family Medical Center.
Liz Helms, California Chronic Care Coalition.
Jerry Jeffy, California Chronic Care Coalition.
Bill Remak, California Chronic Care Coalition.
There are Uber volunteers.
Jessica Nunez de Ibarra, the California Department of Public Health. Just a quick update, I have some flyers on the registration desk. We are at the California Department of Public Health this coming year going to establish a statewide work group looking at how to better integrate public health and health systems, and would love any of you interested in being involved to get in touch with me. We're delineating things, but obviously this work is important, and we'd like to take all of your expertise in statewide initiative.
Jim Ellsworth, Capital Health Network. Capital Health Network is a consortium of community health centers serving the Sacramento region.
Hi, Susan Ivey. I'm at UC Berkeley School of Public Health and the Director of Research at Health Research for Action.
Hi, Andre Mota. I'm a summer student at the UC Berkeley School of Public Health.
Hi, I'm Joyce Sibley, the Director of the Dignity Health's Heart and Vascular Institute.
And Louise Chapu, California Department of Public Health.
I'm Martha Garrity at HealthNet, and I lead up the Health Education Initiative for Cardiovascular Health statewide.
I'm Debbie Odokan with the Health Education Council, and I co-chair with Dr. Arevalo, the Health of Sacramento Coalition's Clinical and Community Prevention Work Group.
I'm Drew Levy. I'm with the Evidence Science and Innovation Group in Medical Affairs at Genentech.
Hello, my name is Brendan Hilly. I'm also with Genentech in our Government Affairs Group.
Lisa Ashton with Health Services Advisory Group.
Warren Barnes, UC Berkeley School of Public Health at Grace Presbyterian Church in Sacramento.
Steve Bryant, Director of Training and Support at Blue Shield of California.
I'm Sarah Brown, WBA Northern California Healthcare System.
Teresa Wilson with Sutter Medical Foundation here in Sacramento. And Leslie Pratt from Sutter Medical Foundation, easy to say. Olivia Consider, Public Health Officer for Sacramento County.
I'm Neil Palazzo, Medical Director, Department of Healthcare Services.
Good afternoon, Desiree Backman, California Department of Healthcare Services.
Hello again, I've introduced myself but already, Diane Littlefield, but just did want to let you know about an upcoming Healthy Community Summit, September 29th, that we actually are partnering with the Federal Reserve Bank. And so I'm going to put flyers out there and have some in the back. Thank you.
Hi, I'm Kylie Hayden, also with the Star Health Foundation.
Hi, I'm Chad Vargas of the Health Services Advisory Group, and I wanted to also give an update. We, through our work with the Cardiovascular Disparities of the Health Services Advisory Group, one of the things we put together is a promising practices innovation package, easy for me to say, for providers to use to work with different ethnic groups and racial groups to address cardiovascular health issues. And many of you in the room either helped us with that or provided some feedback on it. It's now available on the web, and I've sent that out to a number of people. We're going to be distributing that information more broadly this week. So, if you haven't seen it already, we'll work to get that information out to you very, very quickly, and so you'll be able to see it and use it and distribute it broadly and widely, because we really like for people to have the opportunity to see it and use it, and hopefully it'll be helpful for everyone.
Barbara Welcher, Sutter Medical Center, Sacramento.
Dan Tuberty, Account Manager with Boehringer Ingelheim Pharmaceuticals.
Great, thank you all. What I'd like to do now is make an announcement. Dr. Pam Lesh will be doing the next introduction of Dr. Chloe Bird. But I also wanted to announce that Dr. Lesh will be moving on as our co-director, and she's now taking a position with Brown and Tolan, and she's done great work with us, and will continue to work with us as a, kind of a advisor over at Brown and Tolan. But thank you very much for all your support during this time period, and we're really excited. I'm going to be working directly with her as a part of the Sutter Medical Network, so that we're going to continue to work together. And but I want to again thank you very much and have you step up to introduce Dr. Bird.
First of all, I just want to say it's just an absolute pleasure working with everyone. I'm excited about my new position, but sad that I'll be leaving this position. But seeing as I'll be based in the San Francisco Bay Area, it didn't make a lot of sense for me to continue up here as I won't be as familiar with the local environment. So that being said, it's my pleasure to introduce Chloe Bird, who I just found out is a fellow University of Illinois alumni. So it's nice to see some of us Illini out and about throughout the country. Chloe is a senior sociologist at Rand Corporation, and she studies gender disparities in physical, mental health, and social determinants of health. In addition to that, she's also a professor at the Carnegie Rand Graduate School and the incoming editor-in-chief of Women's Health Issues, which is a journal, so very busy. Some of the investigations that she's been working on and is principal investigator on are things such as the impact of neighborhoods and behavior on morbidity, and what she's going to speak about today, which is mapping of gender differences in the quality of care for cardiovascular disease and diabetes. She's been working on this both in California and also for the VA in California and Texas. So without any further ado, please welcome Chloe Bird, and she's going to be speaking to us on the treatment disparities in women's cardiovascular disease.
Good morning. Thank you all for coming. I guess it's afternoon now, just past the hour. I'm going to try to go through a lot of material quickly. I'm going to start briefly with a review of the gender differences in cardiovascular disease and diabetes that are most relevant to this work. Talk a little bit about what mapping can provide in health and healthcare research. And then describe the design of our pilot study and talk a little bit about what you would understand from conventional analysis versus what mapping adds and where we can go from here in assessing and addressing gender differences in cardiovascular care. Now, I know I'm preaching to the choir here. You're all aware that cardiovascular disease is the leading cause of death among women as well as men. And in fact, when you separate out vascular disease or stroke, that's the third leading cause of death among women. It kills about the same number of women as breast cancer, which is what's gotten the most attention. Most women understand that they're at a 1 in 7 risk of developing breast cancer in their lifetime. But they don't know that already 1 in 3 women have cardiovascular disease, and it in fact accounts for 1 in 3 deaths in the US and worldwide among women. Although the prevalence and age-adjusted rates are higher in men, women end up spending more years living with cardiovascular disease. And this is probably because the distribution is somewhat different. Women are likely to die sooner than men are, but they're also more likely to be in the other tail of the distribution, living much longer with various kinds of disability related to cardiovascular disease. But every year since 1984, more women than men have died of cardiovascular disease in this country. So it really deserves a great deal more attention, and that's part of what we're pushing for. Here we're looking both at care among patients with cardiovascular disease and among those with diabetes. As you know, this is a major risk factor for cardiovascular disease. It doubles men's risk. Among women who are premenopausal, it quadruples their risk of cardiovascular disease. So it is a considerable risk factor. You're probably also familiar with some of the trends. When we first started understanding and being able to address cardiovascular disease in men, the rates came down in terms of cardiovascular mortality, and they came down fairly steadily over a long time. It has taken a lot longer to get around to making some of those gains with women. And now the gap, if we look at it as a percentage instead of an absolute size, it's about half as big as it was at the widest point in terms of a percentage. However, if we don't address the rise in obesity, all bets are off as to what this is going to look like in terms of the overall numbers with cardiovascular disease, but clearly the number of women living with cardiovascular disease late in life. It's a major risk. Now, I would feel inappropriate in talking about this if I didn't stop for a minute and say something about what it looks like in men and women. Women do not tend to have the TB heart attack, the clutching chest pain, all the way down the left arm. In fact, they often present with more subtle, less specific symptoms. Women can present with symptoms like throat pain or a sore back. And in fact, and this guideline applies for men as well as women, if you have pain between your nose and your navel, anywhere between your nose and your navel, that increases on exertion and decreases with rest, you need to get this attended to. This is very likely to be some form of angina. Could be stable, it may not take, you need sudden treatment, but often, particularly women, think that because it goes away when they rest, maybe it's not such a big deal, maybe it's not such a problem. The same need to respond quickly applies to stroke. Just because symptoms may respond and dissipate, it doesn't mean you don't need to get attention quickly. And this matters particularly for women because they're more likely to live alone. They're more likely to be making the decision without somebody else there who says, you need to go in and get seen for this. And so very often what we see with stroke in women is that they go to sleep. And sleep is one of the side effects that happens most often. Yeah, okay. Dueling microphones here. So it's very important with stroke that you get in very quickly to get treated because you can only use the clot-busting drugs if you go in quickly. But we have the same problem with women in cardiovascular, with heart disease, so women being. We used to think that men didn't want to go in and get care because they were afraid of being worried well. And it turns out that people don't want to go in and be sick and need to get care. So we need to be as attentive as making sure that women get in and get care as men. The other point is that although the number of people who die with sudden death is relatively small, it's higher among women than men. With cardiovascular disease, and almost 2/3 of the women had no previous symptoms that were attributable to cardiovascular disease. So women need to know that they are at risk. A bigger issue is that the way we approach assessing cardiovascular disease doesn't work as well for the disease in women. Men typically have major artery blockage. Women very often have microvascular disease. They get blockages in the smaller vessels in the heart. And this is diagnosed by ruling everything else out and still getting that it's a cardiovascular disease. So this is a problem not only in diagnosis, but in treatment, because the interventions, you can't just go in putting stents in the same way. You can't just do balloon angioplasty to deal with these issues. So secondary prevention becomes even more important. Because of the differences in disease and our success in treatment, more than 26% of women over age 45 die within a year of having a heart attack, and that compares to 19% of men. All too often, this gets written off as well, but women were a little older. They also have a longer life expectancy at the point that it happens. So I think you need to do a better job in this area. Now, I've been working along with my colleague and husband, Alan Fremont, on this for a long time. We did work, when we first were looking at this, we used a large national health plan with high quality medical records data, and we looked across multiple states at are there differences in routine aspects of care? And at the time, this was funded by AHRQ, the expectation was that there's some differences in socioeconomic group level treatment, and there's some differences racial ethnically, but there wouldn't be differences in gender, or if they did, it was just important to control for it, because in general, women have higher quality of care than men, because if you say get screened, women go and get screened. And if you say this is how you get treated, women are much more likely to get treated. So the expectation at the time was that there are gaps in getting diagnosed, because it's harder to diagnose in women. And there might be gaps in aggressive, heroic treatments and surgeries. That wasn't all worked out. But there was nothing to see here. And in fact, we showed that there were gender differences in care, not only in routine screening, but in achieving control over LDL cholesterol. And we looked among patients who had a diagnosis of diabetes, among patients who had a diagnosis of cardiovascular disease. We also, as part of the contract, looked at people diagnosed with hypertension and whether or not they had control in that group as well. And we showed differences in screening and differences in treatment across the groups. What was interesting was we were looking at patients who had a regular provider. They had good health insurance and they had a diagnosis. And this is one of the best ways to reduce the risk of poor outcomes, and the gaps were there. In one of the other, this one is our study, we also looked at how the relative risk compares to the size of the gap. And you see that as terms of relative risk, women were only 81% as likely as men to have control over high LDL cholesterol based on the standards in place at the time. They were only 75% as likely as men to have control if they had established cardiovascular disease. And it was even worse on control over high blood pressure. The last two numbers aren't as strong because you get into smaller denominators, but the last one is actually significant. You just have to put a lot of decimals in it. One of the other studies that was published at the same time looked at health plans across a different set of states. This was done by my colleagues Chu Wong and Carol Weissman, none of whom are at RAND, but they did this interesting work. And they looked at when you had a gap of 5 percentage points or more, how often did it favor women and how often did it favor men? And it virtually always favored men, except in the hypertension, which was more similarly distributed. And this was true in the commercial as well as Medicare groups, although in the Medicare groups it also favored men. So we've got this evidence of a persistent problem. The work was successful. We had it published in Women's Health Issues. We did a congressional briefing around this. And the main group that responded by looking at systematically at gender differences in care is the VA. And this is from their 2012 report looking at differences. They've addressed it pretty much around screening and other areas, but we're still having differences in control. They look both at achieving control among those with high cholesterol, getting it below 100. And then they look at a second group where they had achieved getting it below 100 or at least were on a moderate dose statin. And that turns out to capture a lot more men than women. One of the ideas was that because it's often hard to get control in women, that this would make the gap go away. But in fact, men did really, there's a large group of men who were on a moderate dose of statin but did not have control. So what could mapping provide when we look at this? Well, statistically, the academic medical articles, we look at establishing there's an average difference. And we either control for gender, or we look at differences and say, on average, across multiple states, among this population, I can do a good job of telling you a difference. The fact is that you usually don't try to intervene to move averages. You try to intervene to deal with problems in the tail of the distribution. The gaps are small enough and there's so many other kinds of issues that plans are trying to address or provider groups are trying to address that it wasn't engaging stakeholders in the way we needed to. So we moved to mapping, which we've used traditionally, not traditionally, but more recently to look at racial ethnic disparities and socioeconomic disparities because where you live is patterned in part by race, ethnicity, and socioeconomic status. We did it with gender, not because men and women live different places, we for the most part don't, but because people know where they live, people know where the plan members are that they're responsible for, where their patients are, and it makes things more actionable and certainly more interesting. It's also important to understand, is the difference the same everywhere? Are there places that are doing better and places that are doing worse? And that can motivate, both give us some insight into what's going on and motivate a different an intervention where there are differences. The data we used came from one large regional California plan, and we looked at two populations, those who had ischemic vascular disease or had had a cardiovascular event in the prior year, and those who had a diagnosis of diabetes, which of course is a much larger population, 155,000 compared to 30,000. We used HEDIS scores, which come from NCQA. I think most people here are familiar with HEDIS quality measures. But the idea behind the HEDIS scores is everybody who's included in the denominator is eligible for the measure, that there's agreement that they should be getting the indicated care. And anyone who has a contraindication is excluded. So it really becomes a direct apples to apples comparison, even when you're looking at people from different geographic areas or different racial ethnic subgroups, in this case, men versus women. Now for analyses, and some of them, obviously we're looking at men versus women, and some of them we looked at whether or not there were patterns by age. by insurance type. The plan included Medicare, commercial, and HMO and PPO, and Medicaid patients. We start by looking at the 8 regions that are used in HEDIS reporting. And then we look by county, by zip code, and for some of the regression models, we took into account area of income. So what does the conventional analysis tell us? Well, among adults who had experienced a cardiovascular event, there was a 5 percentage point gap. 77.7% of men were getting their indicated LDL screening, and 72.8% of women. The gap was smaller among those with diabetes, 76.3% of men and 74.2% of women. But those gaps, that overall quality varied, starting with overall quality varied across the state. It varied across business lines. And as you would expect, there was higher quality in HMO than PPO patients, because part of what HMOs are set up to do is to do an excellent job around screening and around implementing routine aspects of care. And that was supported here. The 8 regions, in case anybody isn't familiar, these are the 8 regions that get used by Integrated Healthcare Alliance to look at healthcare. It's important that I'm not speaking in California. And this was just looking at what are the overall rates. We sorted the plans by their overall quality scores for diabetes because there are more patients there. In general, these are considered very good. Sacramento is Sacramento North, as you saw back here. It's not just Sacramento, so I don't want to implicate anyone unfairly. But Sacramento is kind of pulling up the tail on the distribution here on diabetes, and it's more in the middle of the pack on cardiovascular disease. Here we're looking at the gender difference, the gender gap across the plans, and they're still organized in the same order. And you can see there's only one area where women were doing better than men. And the gap's highest for diabetes in Sacramento North. And the 3 that it's high for in cardiovascular disease were all kind of in the middle of the pack there in terms of overall quality. Now, another way to present this data that we've used with Medicare data and looking at racial ethnic gaps is to plot the quality of care one group is receiving versus the quality that the other group is receiving. So here, if both groups were getting the same care, if women's care was the same as men's, all the data points would line up along the diagonal. All the places where women are getting better care than men are below the diagonal. So if it were just random, whether or not one group was doing better than the other, you'd see the same cases above and below. Here we looked at gender differences across age groups. Because one possibility is you have the problem that it's mainly focused in a particular age group. Now, not surprisingly, particularly for cardiovascular disease, the number of people who qualified for the measure in the 21 to 44 group is relatively small, but the gap is large there. It's narrower in the 45 to 64-year-old group, which we will non-pejoratively call middle age. And then in the older group, it's widened again. We see narrower gaps around diabetes. But again, it starts out with a very large gap, which to some people has been very surprising, given that more often women are diagnosed around pregnancy, they have other indicators, they have more reasons to be getting feedback early on and learning about the kinds of problems. But again, it widens in the older age group. Now, we also did some regression modeling. Here we're adjusting for age, insurance type, region, and area income measures. And we found that women with cardiovascular disease were 80.5% as likely as men to get the indicated LDL screening. And women with diabetes were 94.3% as likely as men to get the indicated screening. Now, for all of these, the gaps get bigger when you look at treatment and when you look at achieving control. But because we're interested in mapping here, we're focusing on screening outcomes so that you have more cases. But I'll refer back to that. And as we've seen in the other models, HMO patients had better quality of care, higher quality scores than PPO, even after controlling for these other factors. So we ran some adjusted models looking separately at the HMO and PPO patients. And women in PPOs with cardiovascular disease were 93% as likely as men to receive the LDL screening. And those with diabetes were 97% as likely as men. Now this suggests that some of the things that HMOs do work. This is an indication that this is an actionable problem to get rid of the gender gap or to improve quality overall. So what is mapping at? Well, here we're looking at the quality using red light, green light coloring. If you look at the first panel for men, the darkest green areas are where the quality of care is highest, and the lighter areas are where it's lower. We're using the same scale for women. It goes down to lower levels because so did care. And then we look at the gender gap to the right. And you see that Orange County was the only area where for cardiovascular disease, women were getting approximately the same screening rates as men among people who were already diagnosed with cardiovascular disease, had a provider, had insurance, and so on. And in fact, in 4 of the areas, the gap is between 1 and 5 percentage points. But in 3, it was between 5 and 10 percentage points, which is getting pretty sizable at a population level. Now the gaps are smaller when we look at diabetes, but still, in 5 out of 8 areas, we saw gaps between 1 and 5 percentage points. But most of us don't intervene at the level of those regions. So we looked at these again by county. Now the white areas are where there were not at least 30 patients with female and 30 patients male who qualified for the measure. Those are places where you wouldn't have a big impact by intervening. That's not where many of the patients are. And we don't want to identify anybody. So to keep the data less identifiable and focus on where the problems are, we're looking at the cases in this way. And you see that in the vast majority of the state, men are getting higher quality of care among the cardiovascular disease patients. The difference is smaller when we look at diabetes. In diabetes, it's only about 57% of the counties with data that men are getting better care than women. About 18% women are getting better care than men. You can also see by what showed up on the right that wasn't in place on the left, the areas where you see a female advantage tend to be very low populated areas where it didn't take as much to move the numbers. This is another way of looking at it in terms of what's the percentage that fell into each of those ranges. If it were randomly distributed, these would pair off like a clock. You'd have as large an area in dark blue as in red. The no gap area would be hovering somewhere around 6 o'clock at the bottom of the pie. And you would see a more balanced kind of difference. So it's clear that something is going on. As a proof of concept, we also went down to the zip code level. And this is mainly because in some areas you want to intervene in a particular way. We wanted to see if this held up, and we saw gender differences. So this is LA County, because we wanted to look at where the population is densest for the state. And it turns out the zip code level differences are about the same for LA County as for California as a whole, with the 32% having moderate to large gaps favoring men for LA County, and 33% for California as a whole. It'd be more likely if we were doing this for an intervention, we might divide these into primary care group service areas, which lump 2 or 3 zip codes together, or look at them in other ways. But because people were very interested, every time I speak to an audience of patients or a general audience, they are very struck by the HMO PPO difference, because they've assumed they were buying PPO care to buy higher quality and not to buy choice, which is what the main thing that you're able to know that you're getting. We mapped what's happened for the HMO patients, and we see it's much more favorable to women. And this is consistent with what you'd see with almost any other disease, where there's not a gender bias in going in and getting care. Women are more likely to go in, they're more likely to get screened, and more likely to get treated. In the PPO, we saw the same pattern we had elsewhere. And that's true even in very high SES areas, some of which didn't have many HMO patients. So what's the point of mapping? Well, it allows us to make patterns of predictors and patterns of disparities visible and actionable, and it's working. We also use it to illustrate whether and where specific relationships occur. So it can help when we bring together a group of stakeholders to look at, is a particular explanation what's driving the problem in a particular case. And that can be very important to getting a group of people on the same page about what it's going to take to intervene, what we're going to be able to do. So we can look at whether disparities map onto socioeconomic neighborhood characteristics, the availability of specific healthcare services. In the VA, we're looking at whether or not there are women's health clinics in the sites. It also allows us to examine patterns of care. So you can add additional information and look at where people are being seen and see, particularly when you're looking at racial ethnic differences, are people getting different care from the same providers? Or are they getting different care, but they're being seen by different providers? Now, partly that's what happens with cardiovascular disease. Men are more likely to be being seen by cardiologists, which is not to be pejorative to people who are women getting primary care, seeing primary care providers. They certainly could be providing a very high standard of care. We just need to provide more education and support around that. But men are also more likely to undergo cardiovascular rehab and stay in rehab after treatment, which, given what we know from all the other aspects of women's care, would suggest women aren't getting encouraged and explain exactly why and what they might benefit from out of that rehab. Now, I had a couple of just-in-time slides I wanted to show you. After I presented this in San Diego, just as our report was coming out, as it turned out, the data group for the San Diego Right Care Initiative, University Best Practices group, met, and they went back and looked separately, without sharing their data beyond that, but they looked separately at what was going on. And they found not only the gaps that we were showing in screening, but that, as we had indicated, there are real gaps happening in achieving LDL cholesterol control. And these are a smattering of plans, most but not all, of the ones that participate in the San Diego Right Care Initiative. And they gave permission for us to show it in this de-identified manner. And they were alarmed. Because this is, whereas there's an understanding, when you're dealing with racial ethnic disparities or economic disparities, it may be very complicated to raise those levels. It may be that they're hard to treat populations, although I don't think that we should let that get in the way of doing something about it. But the general understanding was that if we got the right message to women and their providers, this gap could and should be closed. And so as far as raising their quality scores, and they're very committed to making San Diego a heart attack and stroke-free zone, that this was leaving, I don't want to say money on the table because it's not about money, it's leaving lives on the table. And so they also looked at the diabetes population. Here we're looking at the gender gap, what women's scores look like relative to men's across the same plans. So it matters, and they wanted to encourage provider groups here and others who are involved in making decisions about what gets included, about when we should be looking at gender differences in care and making it part of the routine assessment of quality, that people here start to think about that. The take-home points are that there are gender differences in cardiovascular and diabetes ambulatory care. They're typically small to moderate, but they are sizable at a population level, where even small differences can reflect large numbers of women not getting indicated care. If you're not getting screened, you're not getting treated. If you're not getting treated, you will have poorer outcomes. And this is a real challenge in treating women because they are not necessarily well informed about their risk, that their LDL levels, LDL cholesterol levels go up with age. They go up during menopause and they continue to climb. So there's often an assumption that I just don't want to take another medication. There are much more complex polypharmacy issues for women. Women in general have more side effects from medications than do men. And this is definitely the case with statins, where some women will say, oh no, I know somebody who had really bad muscular pain. I don't want to do that. On average, it takes 3 or more statins to find one that is well tolerated in women. This isn't the case for men. If we don't tell women up front, they're likely to give up and say, just forget it. I don't want to go on a 3rd or 4th statin to find one that works. When I give a talk with a general audience, I'll have somebody who gets up and says, I told my doctor I didn't want to talk about this because I didn't know, or I quit after one statin caused pain. And somebody else will get up and say, yeah, and I went back after I had a heart attack 10 years later, or a stroke 10 years later. So there's a lot of education to do on both sides. But I definitely want women to understand that if they tell their provider, whether they mean to or not, this topic's off the table, I don't want to discuss it, and you don't see your provider that often if you're reasonably healthy, clinicians may be making very reasonable decisions to focus on other things that their patient's more interested in addressing, more ready to take on. So they need to understand if you're missing a very important intervention point. That the evidence here suggests that this is actionable, the success that managed care has had in addressing this, to me means this is something we should take on readily and quickly. And the maps can help inform local and regional stakeholders in terms of what's the problem, what are we missing, what do we need to do. It's been of great interest to the health plans and to women, and fortunately to the media. And they can help address questions as to what's working, what's different in terms of what's going on in different places. So those are the my priorities. I want to take questions, but I have one. First, I want to thank people, and then I have one question that I didn't include that Hattie had already asked me that I wanted to get to. I want to thank Barbara Streisand Women's Heart Center at Cedars-Sinai Heart Institute for supporting this study. And the willingness of the health plan to step forward and share their data because they're committed to effectively targeting gaps in care at the population level. In addition, I want to thank the San Diego provider groups that shared their anonymous data to show what's going on, because I want to use this to help communicate what's possible out of mapping and groups working together the way the Right to Care Initiative has been designed to do, because it can make a huge difference. The one point that I had spoken with Hattie about earlier about some of the differences in care is that one of the risk factors women have around cardiovascular disease that men don't comes from calcium supplements. Men don't usually have any reason to take calcium supplements. But we know from the clinical trials looking at the outcomes associated with calcium supplementation, out of about 10 trials, 3 didn't find any difference, and 6 or 7 showed that women were more likely to have some calcium deposits, which put them at risk of cardiovascular events. We don't see this with dietary calcium, but we do see it with calcium supplements. One of the other areas is that among the people who are compliant with prevention, there's often a feeling that if some is good, more is better. And that is not true with calcium. Calcium is very tightly regulated in the body, as I'm sure there are several people in the room who can speak to better than I. But just adding in more does not mean it's going to go to your bones or even be absorbed. So you have this risk of having calcium deposits. Well, when you have cholesterol deposits, those are these spongy, lumpy, fatty bits that are going in. Calcium deposits are these flaky bits. It's not a good combination. It's something you want to avoid. So it's important that women look at how much calcium they should be taking. For men, it's 1,000 milligrams. For women under age 50, it's 1,000 milligrams a day unless you're lactating and so on. And over age 50, it's 1,200. But overkill is not the answer. And where possible, to be getting as much of that as you can from dietary sources, which even if you can't have dairy, there are green, a lot of leafy greens that are good sources, sardines, there are other things, and almonds and other nuts and so on. The only exception that comes to mind is among leafy greens. Spinach has an acid in it that inhibits your absorption of the calcium that's in it. So it's not nothing against spinach. I love spinach. I have lots of it. If this is made from spinach production, please, I'm in favor of spinach, but it's not going to be your good calcium source. Kale and other things are better. But thank you all for your time. This is just a fantastic group to get to talk to about an issue that is vitally important for women's health and healthcare.
I'm supposedly timing you, and considering that you started 5 minutes late through no fault of your own, you still have 7 minutes.
All right.
And I do have a question.
Okay, well, I was told to leave time for questions.
I'm
so that's
intensely curious to know whether there are any data, or what would be your best guess, whether similarly situated women would get higher screening and better quality of care for CVD, if they have it, if they are seeing a woman primary care physician versus a man primary care physician, and similarly if they're seeing a woman cardiologist versus a man cardiologist. Because the men tend to lack sensitivity toward women's issues in the same way that white people tend to be insensitive to cultural differences in other ethnicities and races, in my opinion.
I'm usually asked that by a female cardiologist who wants the answer to be, it's all okay if you're a female provider. Unfortunately, medical socialization is a very powerful thing, and you get socialized to the norms and standards of treatment. So we don't have any data that indicates that you would uniformly be more likely to get better care on this particular issue from women providers than from men providers. And in fact, what we know on sensitivity issues, for example, of female versus male obstetricians and their understandings of what kinds of pain and symptoms people are experiencing, suggest that there is a kind of myopia that can happen, which may be very helpful in being able to treat people who are going through a very painful experience. But often female OBs are quite shocked at how painful it is to give birth, and this always surprises me because they've been around it a lot. And there are other data that suggest that it probably gender isn't, you couldn't count on it as leading to better care. It might, on average. But there are also a lot of men who are very, very sensitive to women's health issues, and we don't see that gap happening in other areas. Or being sensitive could play out in terms of, this patient doesn't want to talk about this thing, I won't bring it up again anytime soon. You know, what goes in that note as to the decision of what you talk about. Nobody wants to drive away a patient asking 9 million times about something where they're not at a readiness to change point. So I don't know, but I'd like to look further. You and then in the back. Yes, Jessica.
Two quick questions. The first is, when you talk about calcium but not occurring with dietary calcium, does that include where you see something labeled with calcium added, or would that be considered a supplement versus, innate in the food? And then the second question is, can you tell me about the role of inflammation? Because I've heard from women with arthritis that they had a coronary or a heart attack, a vascular event, and that their risk factors were clean, smooth, and that nobody told them that inflammation was a risk factor. But I don't know if they're, from a lay person telling me that, really had no risk factor. So I was hoping to ask you about the evidence of inflammation, people with arthritis, if there's
all right, let me start with the dietary part first. Certainly, most, not all, of the foods that have calcium added it's added to things where it makes sense, that you'll have enough acidity to be able to be more likely to be able to process it properly. So that may be better, but I don't know of studies that have parsed this out in terms of some of the pharmacists in the room, or I will go back and look at it going forward. But the cardiologists that I often am speaking with have not made that distinction. For myself, it's one of the places I would go if I have to use a supplement. But then you're getting into nutraceuticals, which is often just an expensive way to get what you would get anyway. So I don't know. On the second issue, inflammation. Inflammation is associated with everything. You don't want inflammation. I wouldn't immediately assume that because a patient says, nobody told me, it definitely means nobody told me. It may mean I didn't hear it, it didn't make sense to me, it wasn't put in the context. So I'm not sure exactly what that is. I mean, so we see differences in what people report, whether or not they've ever been told by a physician they have a disability, they should use different kinds of physical activity and so on. That gets a little bit mushy. But we certainly should talk to patients more broadly about how inflammatory processes work. I think we probably ought to focus on it in biology in school, frankly. But understanding this is a very major factor in terms of cancers. It's a major factor in terms of many of the problems, the autoimmune related problems that are more prevalent in women, and it's one of the functions in cardiovascular disease. So I'm sure it plays a role, and it's becoming clearer over time. And it's part of the pathway that we now see between infections and some of the things. Inflammation is not our friend.
Okay.
And a diet that reduces your, a diet aimed like with for diabetics. A diet that's aimed at having few processed carbohydrates is associated with reducing inflammatory response. The diet that's really high in all of the white foods, the rice, processed rice, the white bread, all of noodles, and so on, is associated with having higher inflammatory response. In the back, yes.
So Martha Garrity with HealthNet.
I have a quick question about your data.
Yes.
You basically did a lot of gender data. Did you delve deeper? I have two questions. Did you delve deeper into cultural, ethnic specific data in your research?
Not in this particular study. In the prior work, we looked separately at gender, socioeconomic status, and race ethnicity, and they all had independent effects. So it wasn't just one subgroup where you saw women getting poorer care. It wasn't just one income group, but all three are important.
And this was data from one health plan. Was it one health plan that covers a good portion of the Medi-Cal community in California, or what managed care?
It's one of the larger health plans in the state. In the past, when we looked across multiple states, we were looking at something that had a great deal of Medicaid data in the many states we were looking at. So that's not what's driving it, but it's something we could go at further. I would love to be able to get a group of health plans to let us pull their data and look at it so that we could have an image for a higher proportion of the patients in the state at one time, or look more specifically at what goes on in the Medicaid population.
So was it Medicaid and Medicare, or primarily Medi-Cal?
There are both in the plan. Certainly a portion of the Medicare are dual enrollees, dual eligibles.
So we have another question from Daryl from South Family Physicians.
I mean, but I prefer myself personally to see a female doctor. I mean, being a black male, but that's some reason because you can, I can identify, maybe she can identify, I can identify with her more, looking at her as a mother figure and give me the right advice.
Oh, that's interesting. Yeah. Certainly we know that female providers end up spending a little bit longer talking with patients on average than male providers, and female patients spend a little bit longer than male patients. This worked out in the past to be a problem for female physicians because they were often hired in order to handle more of the female patients at a practice, and then not given as good raises because they didn't see as many patients on average as their male colleagues. Hopefully that's been addressed to some extent.
Yes. Kristen Robinson from Kaiser in the North Valley. I just had a question. If your data was looking at physician/NP directed screening and treatment versus a more centralized process like a chronic conditions type treatment where they do panel management or population management and do broad outreach to all patients.
I would love to break it down that way. We're looking at everybody who fit the diagnostic category. With the VA, we're able to look at things a little bit differently. And I can't report on those results yet, but I could say relative to what we've just covered, they're not surprising. But there we'd like to be able to tease out a little bit more of
So we have time for one more question from Dr. Drew Levy from Genentech.
Would you be willing to speculate that there might be other screening procedures or intervention procedures that are competing for limited physician time in devoting attention to cardiovascular issues among women?
Well, since Paul Schickel is one of my colleagues, and he's done impressive work on the number of things we ask clinicians to do and how impossible it would be to cover it all, I'd say definitely there is competition in terms of the time, and yet we know that you can close the gap on screening and not have closed it on treatment. And then that gap on treatment spills over. So part of my concern is if competing things are getting in the way, are we sure they warrant being in the way, or is there a better way to optimize what's getting that, the front seat or one of the seats, one of the things that does get covered? And that would be very interesting. It may explain some of the differences across plans. There may be actually interventions that were put in place to do something that have come ahead of this. I don't know. Thank you all very much.
Thank you, Dr. Bird. That was a great challenging presentation for us who work in health systems, because it may be that this is really a system issue problem that we need to address or solution. But this is critically important, and we really appreciate you giving us the opportunity to realize this, because many of us were unclear about this before. So what I want to do is take the opportunity now to introduce our next speaker, Dr. Winston Wong. Dr. Wong is really well known to many of us because of his pioneering work with Kaiser and the work around healthcare disparities. And he clearly has a great CV and a great bio, and is going to bring some of his learnings from Kaiser on reducing disparities and the work that they're doing on particularly cardiovascular type of risk factors that we're all interested in. So without any further ado, I want to introduce Dr. Wong. Thank you for coming.
Well, good afternoon, everybody, and I certainly would invite you to stand up if you want to stretch in between your little break between speakers here. We at KP, we feel that if you sit down for more than an hour, you start destroying.
Let's do it. Let's make that our norm.
Take some big breaths, stretch out. No one's looking. It's just okay, thank you. And Jose was very kind in his remarks that he asked me if there was anything special I would share with you. And I was actually listening to Dr. Bird's presentation. I am a native Californian, okay? And on top of that, as I was sharing with some folks, I'm a Cal Air alumnus. And then the third thing is, my nephew is a highway patrol officer around here, so be careful. It's really good to be with you. And I think this microphone is kind of a challenging thing. But
you can bend it more toward you, I think.
yeah, my voice tends to project okay.
That's better.
I'm really happy to share with you in the next 40 minutes or so some of the work that we've done at Kaiser Permanente in our journey to address disparities. And I was looking at our slides. I'm going to cover a lot of material. Actually, I probably could share with you a presentation that could be 3-4 hours long. Literally, I've been able to do that before. We're going to do some work around how we use data at Kaiser Permanente, how we systematically address issues that we identify as clinical disparities, and then how we engage care teams. And really, ultimately, and I'm a primary care physician, I'm a family physician, how does this really make a difference in terms of the interactions that we have on a day-to-day basis with folks that we're really accountable to, we have an obligation to in terms of providing the highest quality of care. So let's go on some of these points, if you will. Now, this is the pie chart, and I was listening, Kristen, you're from Kaiser Permanente, right? So as you can see down here, there's something that says it's for internal use only, so don't internal use only.
So do you?
Depends how you define
No,
internal.
Can you send us another slide that
No.
pulls that? Because otherwise we
pull it.
can't post it,
Oh,
and
really?
it's so
Well,
important.
the thing is, it says 2011, see, so this is 3 years old. But I'll try
Sorry,
to do that.
Winston, I'm gonna have to ask for that revision.
That's fine. But I want to tell you, it's 3 years old, right? So the data changes. And as our colleague here, who I think Dr. Simon, you were mentioning, you're getting an influx of new members through the Affordable Care Act. We are getting new members through the Affordable Care Act. And if you look at this pie chart, I'll point out to you, for example, more than 50% of our membership of our communities of color, right? African Americans alone constitute nearly 1 million folks as part of our 9.2 million membership. The 9.2 continues to grow, the Affordable Care Act. My point being is, when we look at disparities, it is a moving target. So don't think that you have a snapshot, okay, we're going to do something, and thus the denominator is constant. The denominator is constantly changing. I've been trying to relearn calculus because I want to be able to do the actuarial kind of analysis with regards to if you have an influx of new members with more chronic disease or more burden of disparities, what does that happen ultimately in terms of your curve around clinical outcomes? So it's really important, I think, in terms of looking at the demographics from that point of view. Kaiser Permanente is probably, like many of you, experiencing the shift, the browning of America, and we're proud of that. I think that's what we have to do in terms of how we address the whole pot with regards to achieving clinical outcomes. Now, I think this goes without saying, and I think all of you are struggling with this as well as me. I mean, we can always take the approach that if we have a really good quality healthcare system, we just do things consistently the same for every member, every group that we see in our care system. But we know that one size does not fit all. And it is really the tension of organized healthcare systems as to how do you think about an issue such as so-called mass customization. We have to think of 9.2 million folks. At the same time, we have to kind of attenuate how we understand how individuals have different approaches, different beliefs, different expectations of the healthcare system, and thus in that terrain be able to achieve high levels of quality. Now, just to remind us, and I'm going to be focusing principally on hypertension today, but I will not be totally focused solely on hypertension. But I think hypertension, particularly among African Americans, is a really important issue. Because the fact is, the burden of hypertension among African Americans is really out of the universe relative to other populations. The stroke and mortality rate is 6 to 13 times higher between African Americans as compared to Caucasians. It is so endemic in the community that African Americans almost feel it, and you can attest to this, it's part of living and dying. High blood is part of living and dying. I don't believe that high blood pressure is something that we should just take as the natural route of a huge group of Americans and saying that that's just based upon stress, it's based upon genetics. No, we have a basis in which we look at the disease and we know what the science is with regards to caring for high blood pressure. Therefore, we should not see any disparities in high blood pressure control. It is not part of natural law that we see disparities between our different racial and ethnic groups. As you can see here with these graphs, the prevalence as well as the control. Prevalence is one thing, but the control lags behind too. So we are failing on two counts. Failing in terms of detecting and screening, and failing to treat effectively. And that's really what the issue is here, with regards to even how we look at it, Kaiser Permanente. Now, the question came up when we looked at this as a question for our board of directors. What can we assume at Kaiser Permanente? And I'm sure you're familiar with our system. We have to assume that everyone has pretty much, quote, equal access to the healthcare system. There's similar processes in the care delivery structure at Kaiser Permanente. We have an astounding electronic health record, one of the largest electronic health records in the private sector. And we have the advantage of having prepaid. We have no excuses in terms of people saying, oh, I can't afford it. When people come in, should be able to get the full advantages of our integrated delivery system. So this was the question that actually I had to kind of go in with a number of my colleagues at Kaiser Permanente to try to explain what is happening within Kaiser Permanente and what do we know with regards to an issue of hypertension. You may have seen some of this news. KP does really well in cardiovascular disease. In fact, I was driving up on Highway 8 today. There's a big billboard around Vacaville or something like that, and it says, it's not really, I think the color of the billboard is a little odd, but anyway, because it says heart attacks, and it says that Kaiser Permanente has reduced serious heart attacks by 60%. This is true. And there are many reasons for that. And I've talked to the cardiovascular experts, our physician leads around why is this so? And it's very interesting. You know what they say? They said, Winston, what we do is very mundane and it's not sexy. It's not about having the great app. It's not about how we have these folks that are just like charismatic in the exam room. It's about systematically going at this doggedly. doggedly with regards to registries, with regards to expectations around keeping true to the algorithm, and then customizing accordingly. That's would be the 3 pearls that I would put across.
That should be on an ad.
That should be on an ad, thank you. Now, this is kind of what you see here. So if you look at Northern California, and this goes up to 2008, this one doesn't say for internal use only, and you can see the lines with regards to all circulatory system disorders, and here specifically around heart disease and stroke. We see these dramatic decrease, among Kaiser Permanente members per 10,000 person years in the cardiovascular death rate. So we are doing something right. There's no doubt about that. Now, are we doing something right that's distributed equally across all the different racial and ethnic groups? That's a really interesting question. Now, I had some mixed feelings about using this slide. Okay. The reason why is I think it actually is pretty good with regards to looking at all the arrows, the counterposition of interactions in the physician-patient encounter. As a family physician, I think that this graphic accurately depicts all the factors that occur in the physician-patient interaction. What I think it doesn't do that effectively, and I actually wrote an article about this, is the third party in the room. And what is the third party in the room when you go in and see a patient in the exam room? It is the payer, it's the insurer, and the systems around it. So while I think this is effective in pulling out that things like patient satisfaction, intensity of intervention, the process of care is critical in terms of getting to reduce morbidity and mortality, it's also about what systems infrastructure that you have behind us. And I would think, if you can see in the next few slides, this will, my slides will amplify the issue with regards to having a good healthcare plan and healthcare delivery infrastructure behind you. So, this is probably the most significant graph that you'll see in our presentation this afternoon. And it is the graph that we show across many, many different measures, trying to make it accessible not only to every physician and every provider, but every healthcare team, every organized labor member within Kaiser Permanente. It is the basis of which we understand health disparities. So this is the code that I want you to look at this graph. The red line, which you can see on the bottom, is performance for 90th percentile HEDIS. Okay, in other words, any line that it goes above the red line means you're performing better than 90% of health plans that report on HEDIS. The green line, kind of in the middle, is what Kaiser Permanente is doing for all its members. So in this one, high blood pressure, you can see our green line with regards to high blood pressure for all HEDIS plans is well over the 90th percentile. Now the interesting thing, and I was talking to Dr. Bird, her husband, who really helped us in this regard, was to put in a methodology to disaggregate the data with regards to all members. And as you can see color-coded here, we have split out the different major racial ethnic groups. There's another question methodologically whether we can split out even better than these major ethnic racial groups. But as you can see, the Hispanic in orange, the lightest blue on top, Asian Pacific Islander, the blue that kind of corresponds very much with the green line is Caucasian white, and African Americans is purple. All right? So what is really interesting, and as I like to point out, it's like, if we had a member plan that was 100% exclusively African American members, we'd be performing over 90th percentile for all HEDIS plans. That's something really good. Now, the other question, though, is if you look at the pattern of the lines, what's happening to the pattern of the lines? Okay. And there is a gap that's persistent. And what the barcode is to look at the absolute disparity gap between blacks and whites with regards to high blood pressure control. 7.3% back in 2009, and fast forward 2 years later, 3.8. Okay. So, I was talking about calculus. changing the denominator, we have to accelerate change with regards to targeted groups that we know exhibited disparity. Okay. I can come back to this slide in a second. Now, does this all happen by accident? It does not happen by accident. It happens by a very deliberate attempt, commitment from leadership to look at disparities as a systematic part of our quality agenda. As you can see here, and I'm not going to go through it in great detail, but our board of directors and our National Quality Committee said, it's not just good enough to look at HEDIS broadly, we need to look at HEDIS disaggregated. And we put together the so-called equity dot as part of our quality dashboard. And I'd be really curious in our discussion, in your quality dashboard, which I'm sure all your organizations have, how much of it is pulled out with regards to the question of health disparities and health equity, and what experience you have with it. For us, it was really a great breakthrough in that it made a commitment that we want to be transparent with regards to the disparities we see. Conscious about time, we've got about 20 minutes, right?
You do have 20 minutes, and they warned us that the Medi-Cal program had a meeting that they had to go to.
Well, you know, Medi-Cal folks need work.
They could use some of your genius ones.
But anyway, so this is the point of this slide, is to be systematic, and we provide on our quality dashboard a quarterly summary of where we are. Every quarter, based upon the electronic health record, where we are with regards to every aspect of the dashboard, which includes patient safety, includes utilization, and now includes equity, quarterly basis. So not quite real time, but important. Now the other breakthrough that we made is to make a declaration based upon the measurement. And I think Dr. Berwick actually coined the term, you know, sometime is not when, or somewhere, you know. It is true. We can't just say, you know what, we're concerned about disparities, we're going to make disparities, you know, it's something that's important to us. We actually said at Kaiser Permanente, and our quality committee and our board of directors said, you need to set a target, and it has to be part of how leadership is evaluated in terms of achieving toward the target. Right? That makes a lot of sense. So I'm really proud that we have these commitments here. It goes up to 2013, it goes beyond 2013. But to say that we will decrease the high blood pressure control rate between African Americans and Caucasians as a disparity by 25% by 2012, by 50% by 2013, and dare say 100% by 2016. It is not acceptable, and we have the basis to erase a specific clinical disparity. And we're doing the same thing for colorectal cancer screening in Hispanics. Why do we choose these things? You look at your quality dashboard, you probably have dozens of different measures. You could pick out 10, 15 different measures with regards to where you see a disparity. We have to get some alignment here. We have to get some sense of prioritization, because otherwise your work becomes totally dissipated and you'll never get to end goal. It's like going to the moon. You know, I would say, you know, if you said, oh, you'd like to send people up in space. You know, when President Kennedy said, we're going to land a person on the moon, it was very tangible. I can tell you this, that in hypertension among African Americans, we're down, like the disparity is more than 60% reduced. There are some voices that say, you know what, we've done better, let's go and do something else, diabetes, prostate cancer, something. I said, you know what? What would have happened in Apollo 10 if they said, we got down to about a mile on the surface of the moon, and we can do it, we're going to turn back down, we don't have to show anything, right? You actually have to get to the surface of the moon, and you have to get to a place where there's no disparity between African Americans and hypertension and control rate. And that is the basis of which you make a commitment and where you align your work. So, this is a very busy slide, but it is not meant for you to go into detail.
It's a great slide. I love this slide.
Okay, because what I want to show you here is that every medical office has this set of data. And what does this set of data show? It shows all the measures that we are concerned about, and it shows where we are with regards to percentage. I can show it to you because it's 3 years old, because it's, you know, you can't bring this back and say, hey, look at Kaiser doing 2014. It's not, this is 2011. But we also are systematic in terms of disaggregating the data with the racial and ethnic groups on top, as you can see, color-coded. Okay? And then when you look, your eyes go to where the opportunity is, and the orange places are where you can go first. Minority groups rate was significantly lower than the white rate, and lower than the HEDIS 90 percentile. Improvement, improvement, improvement. Now, the other thing that I think is really critical here is the third column. Why do I say that? What's the third column?
Can you read it to people, because they won't be able to do that
Okay,
from
it
the back
says,
of the room.
the third column, okay, let's look at the pink column. It says Black and African Americans. That's so what all our Black and African American denominator for those different measures, okay, is purple, right? And it shows our rates for equality for the African American membership for that particular medical center. But the column right next to the percentage is a real number. Okay, so a medical center has the numbers they need to know. What would it be? How many folks do we need to get under control or get screened to achieve the same rate as Caucasians? That activates your care team and says, we can reach, in this case, let's look at, should be the hypertension here, looking here.
You've got cardiovascular LDL as one
Yeah,
of your
if you look at
spots.
LDL, if you look in the 4th, 5th, and 6th rows here, cardiovascular patients, LDL screening, LDL control, and controlling high blood pressure, and you walk across to the African American column, you would need to get 161 folks to get screened to get to the same level of screening for Caucasians. Or more significantly, you need 6,500 folks, 6,400 folks to get their blood pressure under control to achieve 90%. This is really important because if we don't have real numbers, it doesn't ever get real for people. And it doesn't measure, doesn't align with what people have to do to get to their quality target. Right? So
I'll commit to all of you who want to look more closely at that slide that he's going to send me a deck that doesn't have any confidentiality elements, and then you'll be able to look at it more closely. It's got some really great
can't say no to
teaching
that,
information.
Kristen, don't touch it. Okay, so I went back to this slide that you saw earlier. Okay, so we do this on a quarterly basis, and we're looking at disparities. This is program-wide. This is, if you look at the pink line, remember, we have about 1 million African American members. This is about 100,000 people, right, with high blood pressure, maybe 150,000 folks. And we need to accelerate the curve with regards to the improvement in the African American population as quote, opposed to the other groups. So there is a philosophy. Does a rising tide lift all boats? Yes, it does. But if a rising tide does not get rid of disparities, there's always some boats that bobble differently. So we need to be able to accelerate the changes. Now, how do you accelerate changes when you see this kind of phenomenon? And that's the challenge for all of us, I think. I'll show you a little bit with regards to diabetes care, which is a different story. This is hemoglobin A1C, which I know that you're also looking at. Where's our 90th percentile? We're not quite there for all members. And it's very interesting that if you break it down, Latinos, African Americans, Asian Pacific, it's basically parallel, right? So we actually have some work to do with regards to accelerating the rate of change for the different disaggregated groups. On top of that, we have to be able to look at where the diabetes prevalence is. This is not, so as you know, Latinos have a higher prevalence of diabetes than Caucasians, and the denominator keeps on shifting. So again, let's look at it from all sides perspective with regards to the data. I'm going to go through the next few slides relatively quickly, although they were just as dear to me as the first few slides. What do you need to do then? And this is the next two slides. If you could jot down anything you want to look at, this is what I would say the take-homes are. You need data that's actionable and current. Registries, which I think we're all really, either in the midst of it or we can feel it. We need clear clinical algorithms. Clear clinical algorithms. Do you believe the science is evidence-based, and do you believe evidence-based makes the difference? I hope you say yes. Because if that's true, then you should ask every physician how much are we really adhering to the guidelines that we believe are true. Okay. Now, there's always variance. And we need clinical interventions that take into account and expectations of priority populations. Priority populations. The next view, dissemination and adoption of practices that make a difference in the patient experience and patient interaction. Ultimately, when it comes to a therapeutic relationship, a patient has to make a decision with regards to the value proposition of changing something in their lifestyle, whether it's eating, whether it's exercise, whether it's taking a couple of pills every day. That's a decision, right? And some of us find it relatively easy to take a physician's advice, and some of us find it really difficult because there are a lot of different reasons why. And if we don't, our family members probably do, right? Supporting multidisciplinary teams, because it's not just about the physician, and considering and factoring community-level education, outreach, and engagement. That's the other interesting thing, is I've read a study recently that if you look at disparities research in the last 10 years, where disparities is like the flavor of the month, 75% of the articles with regards to disparities have to do with changing patient behavior as opposed to changing systems around caring for patients. So we're really concerned about how patients are able to adapt to our expectations rather than the systems adapting to the patients. That's the last point. I apologize, this doesn't show up so well on the screen. I'll read it to you. We know the key components of successful BP control: appropriate medication, appropriate dose, algorithms, follow-up and monitoring, medication adherence, lifestyle modification. So we know what you need to do to get to blood pressure control. Why do we fall short when it comes to different population groups? And this for the physicians and other providers in the audience. We have a lot of folks at KP working all the time around clinical guidelines. And this is what we do. We say thiazide is foundational, dose is important. Max dose, ACE, ARBs, we have it there. We actually use Prinzide now as the drug of choice, combining ACE with thiazide, and we say spironolactone needs to be the add-on for particularly African American patients.
Winston,
yeah.
Can we just do a little bit of foundational here? And one is, you're saying by this slide that the treatment for this group has to be somewhat different. So you skipped.
No, actually, I haven't said that. We do this. This is, how many of you are Kaiser Permanente team members? Not many of you, I think, because most of you are health plan folks. But you're Kaiser Permanente, and I don't know if you have high blood pressure. I'll tell you the truth, I have high blood pressure, okay? And the physician knows, by all the folks that we care of, what's most effective in terms of getting that blood pressure down and the chances for adherence. So we abide by that. And we don't say, you have to consider something else, if so-and-so does this. We say, this is your core. Now you can add on, and you're a physician, and you know how to make decisions. But let's go to the evidence and what evidence is shown and simplify rhythm algorithms. Yes.
So this slide says for a particular ethnic group, so that would indicate that you create a different protocol by ethnic group?
Well, in this case, with regards to the opportunity to improve control in African Americans, we found that there was a slippage around adherence. I say adherence in the algorithm. So if you look at our algorithm for hypertension, some of the physicians would say, oh, I tried something else because the patient didn't like it, or because we know that it's not as effective, we say, look, you need to be able to intensify accordingly to the algorithm, and intensification taking in accordance the African American population. Because a lot of the failure of therapy is not because people aren't on the drugs. It's because the drugs have not been intensified accordingly. Okay. In fact, typically, you know, a lot of patients come in with 5 or 6 drugs for the same condition, and they don't even know what they're taking anymore. And it's a morass. So this is really trying to emphasize around the algorithm for African American populations, how to intensify.
So why don't you continue for another, say, 7 minutes, and then we'll start Q&A?
Sure. In other words, speed it up. Okay, so I'll just, so when we actually met as a group in terms of trying to leverage not only practicing providers, but also the quality folks, and most importantly, the researchers. As Dr. Berger, we actually think the researchers have a lot to do with in terms of improving our clinical practice. We looked at the disparities work and said, these are the things that are really important, that are particularized with regards to high priority populations. As you can see, it's not just about patient behavior, it's about access and also the relationship between patients and the physician and the community. I'm going to skip over this relatively quickly, but there's a lot of opportunity for providers to be a little bit better coached, let's say, with regards to how to talk to different population groups about a condition, chronic condition. One is demystify the problem. Okay, have a conversation. Sometimes it's okay to personalize the conversation. Like I just shared with you, I've high blood pressure. I think if a patient heard that, they would say, well, I'm actually not that even different than Dr. Wong. And he's taking medication, he looks okay, so why shouldn't I take it? Or why do we emphasize that we're looking for something? Or if you say something to a patient, let's try this on you, I'm not sure if it's going to work. That's not inspiring a lot of confidence, right? So we need to be able to have the right kinds of conversations with different population groups, and we do this kind of coaching. We've done this coaching down to a very specific aspect of how the interaction is supposed to go. Yeah.
That was such an important slide. I was wondering if you could just spend a few more seconds on it, because it really, for our standpoint, maybe it's because of our bias, but some of these points that you have further down the line are so critical. I was wondering if you would mind just spending a few seconds.
So I got that happen. Or, yeah, sure. I'm more than happy to. Demystify the problem. And I think what's really interesting, some of this is what we've learned from what pharma does effectively. Yeah. So I always pondered, no one knew what restless leg syndrome was until the pharmaceutical industry suggested, that's something you should be concerned about, and put it in layman's term. So when we talk about something like high blood pressure, or we talk about colorectal cancer screening, we have to be saying it's pretty common, right? And we know how to take care of it. It causes heart attacks and strokes. Set the standard for expectation. Oh, you know what? Actually, in the United States, 3.5, 4 out of every 10 adults has high blood pressure. And the problem is only 60% are controlled. So we set the standard for expectation. Make access easy. So instead of saying, you know what, you can only come to the clinic between these hours, we set up opportunity for you to drop it anytime you want to get your high blood pressure taken. And in fact, you should take your blood pressure at home. And we'll show you how to take your blood pressure at home. And there's new technology, of course, on the horizon to make that really efficient. We encourage loved ones to be part of the conversation. Because in many communities, they have sacrificed so much as individuals. They're ready to sacrifice their health. But if a loved one says, you know what, Dad, I want you to be around for my high school graduation. I want you to be around to see your grandchildren. It changes the conversation. Emphasize prevention over screening. So this is particularly around colorectal cancer screening. It's a different conversation. You say, you know what, we need to do this because we're going to look to see if there's an early cancer. As opposed to, we can get a cancer before it happens. colon cancer is entirely preventable as a cause of death. Encourage healthcare providers to suggest prevention as opposed to screening. I'm looking for something as opposed to I'm wanting to prevent something happening. And then normalize the discussion, as I just said, emphasize cure rather than discovery. I think the cute thing about normalize the discussion, the best commercial I've seen is when, let's see, what's his name? Ditka, you know, remember Ditka? The linebacker and coach of the Chicago Bears. I never thought he'd be talking about his erectile dysfunction in front of millions of people. Because he normalized the discussion, right? And it actually meant that, well, if Ditka can talk about his ED, I guess I can talk to one doctor. So if we normalize the discussion as opposed to having discussions sound like we're deviant, then we've achieved a lot more. So thanks for asking for me to share that with you. We have done specific aspects of how to coach. And you might have seen these things. AIDA is what we're trying to promote: acknowledge, introduce, duration, explanation, and thanks. And there's a particular role of this in priority populations because there is historical mistrust of the healthcare delivery system in many population groups. And commonly Tuskegee and syphilis and African Americans are mentioned, but you could name Native Americans, you could name different population groups that have been victimized by whatever. And there could be mistrust in the system. These are some of the things that actually our cardiovascular hypertension champions have really tried to emphasize among our, oh, I want to go back there. The use of surname is important. As opposed to, you know, Molly, let's take your blood pressure. Mrs. Jones. No one asked you to address Mrs. Jones by the term Molly. It's already an equal relationship. The use of touch. We did a lot of ethnographic work, and some of our patients said, this doctor not even touched me. It's like I'm like a leper or something like that. The use of touch is important to communicate a trusting relationship. And ask about family and support network, the role of religion, church, and spiritual beliefs. What do you do at work? How many times do physicians actually ask patients about what you do in a typical day? Very little, very little. And concern about experimentation. Let's try this drug is really different than versus this is a drug that we know is effective. Need for direct communication, and thank the patient. Thanks, Mrs. Jones, for coming in today, for making a commitment for you trying to be healthy and maintaining your blood pressure. I want to work with you. Going through this really quick. We use this kind of approach in terms of breaking down the strategies. I won't go through this because what's important is you see these different strategies lined up against an algorithm for disparities in hypertension among African Americans. So if you can see on the left-hand column, it says improve hypertension control among African Americans. How do you actually actuate that? You use your clinical management goals. These are evidence-based aspects of what we know is systematically appropriate to do effective blood pressure control. We figure out the leverage points. Where can we make a difference? We specifically target disparities, areas for a reduction, and then the proposed reduction strategy. So this is actually outlined. You're used to seeing different algorithms with regards to, refer for CT scan, do a biopsy, blah, blah, blah. It should be as systematic as anything with regards to disparities. Finally, I wouldn't leave out this whole aspect of community engagement, which you're probably all here about too. I mentioned to you at Kaiser Permanente, we've made a big difference in blood pressure disparities, but we haven't got there yet. We haven't touched the moon yet. And it's my belief that we'll touch the moon when we really understand how to engage with communities. And because it has to be amplified throughout the community, that high blood pressure is controllable, it's treatable, and it's going to enable you to live longer. And as you can see all these aspects, we have to address these things, the things of chronic stress, the so-called adverse childhood experiences. We need to get, and the top, maybe something, can you recognize what the top right-hand corner is? It's the barbershops, right? And I like to point out barbershops is not about vanity. It's about investment of men to their health and appearance for their communities. And we are actively engaging different barbershop kinds of arrangements where they can be a more active part of the healthcare team. And then we're looking into how we interface with different faith groups and different ways of connecting with congregations where people can make the connection between their spiritual and physical health. And obviously things like salt and dietary intake are really important. The last slide is, you may have seen that Dr. Steve Sidney got a major grant that's going to address blood pressure management among African Americans in Solano and Napa Valley. This is the article that appeared in the Chronicle, if you'd like to see it. And I think it's really about what makes a difference for a high priority group. Is it all about what happens in the medical exam room, or is it also about community engagement and education, and how we amplify the opportunity to get an all-sided perspective to support families in getting their blood pressure controlled, and ultimately just have a healthier community. So I covered a lot of ground, and you can tell I'm enthusiastic about this work. I think it is imperative for us, with you as part of the community, imperative for this healthcare delivery system to become accountable for the disparities that we see. It's not tolerable, it's not natural, and finally, it's achievable for us to eliminate disparities. So thank you.
So we're going to go into our question and answer period, and so if anyone has any questions for Dr. Wong.
Yes, please.
Joyce Higley with Mercy.
So we are always, in non-integrated approaches are always envious to the ability to be able to capture the data and use it as your driving force in the care. But so with hypertension, with the JNC8 piece,
Yes.
how how simple is that for you to slide in a change in an algorithm into the daily practices of all your physicians?
We actually, many of our hypertension leads were part of JNC8, Dr. Joel Hadler, Dr. Joel Young. So we actually think it's quite consistent with where we've been going anyway. I think it requires us to be more diligent about understanding the risk calculator and figuring out where the opportunity is for high priority populations. But we will, it's not going to be a big step for us to incorporate GNCA. We actually think it's a natural evolution of how we've been practicing. And as I mentioned with you, when you talk to Dr. Young, Dr. Jaffe, Dr. Hadler, who wrote the article in JAMA back in August of 2013, they consistently said, Winston, it is not about us doing anything special. It's just about us being very diligent and being thoughtful and methodical about getting people under control. Now, typically what happens is that people come in, have high blood pressure, diagnosed, they come in for one visit, get therapy, and then there's no follow-up until 3 to 6 months later. That doesn't happen in Kaiser Permanente. In fact, I've talked to a number of members, they're harassing me, they're calling me every month about my blood pressure. And actually, that's probably the way it should be. One of the opportunities we have is we kind of know what the magic number is for harassment calls with regards to getting people to actuate. So that's really important stuff.
So what is the magic number?
It's about 2.8 or 3, yeah, from what I understand, yeah. Thank you, sir.
I want to ask you, for patients that just come in and you just learn that they got hypertension, would it be good to recommend them to a class to teach them how they can control their blood pressure right away?
Yes, we do. We say there's an opportunity for you to go to your class. You don't have to. And there's a number of folks there that have the same early diagnosis with you. They talk to you about your fitness, talk to you about lifestyle changes, talk to you about choices you make in terms of your diet. And you may not start a medication right away, but eventually about any stories that people might have with regards to how to better use your medication, or whether there was a side effect of your medication, and what options a physician has. But it is about looking at this whole aspect of a totality of different opportunities to support patients and where they are. Very interesting story, sir. In one of our regions, we actually had a better hypertension treatment rate among African Americans as compared to Caucasians. In other words, a so-called reverse disparity, not a really good term. And the question was to this region, what are you doing that's different? And the physician leads there said, you know what? We're not looking at this as an African American kind of priority project. We just look at the fact that we have a population in clinic that has a lot of African American folks, and we just don't we're like a dog with a bone. We make sure that when a person is diagnosed with hypertension, they know it, they know that they need to be treated, and we check blood pressure not just once, not just twice, but 3 times whenever they come into the clinic. They use the nursing staff and the clinical staff to help them do this, but it emphasizes how important this is relative to your SOAR needs. You know, in the long run, it's much more important than your SOAR needs to get the point across with regards to how important it is for blood pressure.
What about the people that's not with Kaiser?
Yes.
And they go to other different clinics or different other, you know, establishments? That, you know, can they help them with their blood pressure or like check, change, and control?
Yes.
It's a good program.
Well, I'm really glad you mentioned that because we've been actually in very earnest discussions with the American Heart Association about leveraging their program of check, change, and control and supporting that as a community-wide initiative. And as Hattie knows, we've been working very closely in San Diego with other partners. Yeah. Hattie, you want to mention something?
So I wanted to mention and ask for your help, Winston. So Winston has these great data sets, and what we have in our packets every month is this astounding information that Sacramento County has higher incidence of heart attack and stroke than the rest of the state, quite significantly, and among younger populations. And I'm wondering, please pass that to him. I'm wondering if you could take a look in your data.
This is like a pop quiz or something.
So it's just at the very top there, you see a very significantly higher rate of heart attacks and strokes here in Sacramento. And I just would like to ask you if you can look in your data to see you believe the basis is, because we can point out the problem. And then secondly, to see if you can help us engage Kaiser more in this community endeavor to reduce heart attacks and strokes community-wide. For instance, with our linkages with the check, change, control program, because it is a population-wide problem in Sacramento. We all need to pull together on it.
Well, you know, I'm not sure if that's a question or a challenge or like an invitation, but let me say a couple of things. One is, I think, actually, as Dr. Bird shared with us, there's an opportunity for much more transparency and a collaborative approach to address this. And I think this is really what you're emblematic of. Now, how transparent and how much data is shared, as you know, Hattie, a lot of that breakthrough was made in San Diego, right? And I don't know if you also heard, San Diego got a recent several $1 million grant from CMMI.
They're just our most mature community, so it will happen here in time.
Yes.
Yeah.
So, but the thing is, where do we use data to generate the opportunity for, number one? One is, where are these folks living, as Dr. Bird showed? What is the ethnic breakdown of this? How do we measure whether people are actually getting therapy? Getting screened, number one, getting therapy, number two, and getting adequate therapy, number three. Those are the 3 issues. And I don't think you can attack one without looking at the others. So I'm not an expert, I don't live in Sacramento County, so I don't know where all the different population groups, but I think that's where we need to leverage and not just go kind of blindly and say, let's just do blood pressure. We have to know where the priority populations are and where the energy should be focused. And it could be focused around whether there are aspects of not having promotion of a really strong algorithm. Are there aspects of where screening is low? I don't know. But I think those are where the strategies might really lay with regards to understanding the particularities of Sacramento County. Not bad for a pop quiz answer, I think. But,
So do we have other questions for Dr. Winston Wong, or do we want to move on to the general questions at the top of the agenda to discuss as a group? Does anybody else have any questions for Dr. Wong?
Yes.
Just a kind of a point, you know, one of the things that we're interested in is the use of community health workers.
Yes.
Especially in populations that are, you know, at high risk, who have some, like Medi-Cal type populations. And I know when Medi-Cal patients enter Kaiser, of course, they go straight into the mix and they're just like anybody else. But has Kaiser had any experience with reaching out with specific projects around community health workers?
Thanks for asking that, Jose. In fact, we do. A lot of it has been done in Southern California, where we're working with promotoras to be more effective with regards to our diabetes control. And as I showed here in the slide, with regards to getting some initial foray around working with folks that are trusted in community, barbers for this in this instance. And I think what's really important here is not, I think we have, at KP, I think we're understanding the limitations of the clinic setting as opposed to folks that are embedded in the community that know the language, literally and figuratively, as well as are viewed as peers, trusted peers. And those are, I think that those are probably, you know, we're down to about 3% disparity. I think that that's about at least 50% of the equation to get there. And how we do that in a community-wide basis and share folks, I think, actually concretely, is one of the opportunities that is in front of us. Well, thank you for your time. I appreciate it.
So as Hattie had mentioned, one of the things we do here is engage your thoughts about some of the key things that you learned today in both lectures. And so we have a series of questions, learning objectives that we wanted to just throw out to the group and see if we could stimulate some discussion and some potential knowledge development. So the first item is describe proven approaches for reducing disparity and achieving high levels of clinical control for blood pressure, lipids, and blood sugar for all ethnicities and gender, and the gender differences in your projects, if you have any learnings that you can share with us.
Maybe Jim, you could comment on how you use ethnicity information with the community clinics of Sacramento. Does that factor into your challenge, or is it you don't have the electronic infrastructure to do it yet?
Thank you. And, you know, we heard from Dr. Wong about registries and the value of registries and the ability to benchmark and measure. We're in the process of building that registry. And until we do, we're really guessing. And as long as we're guessing, we won't be able to pinpoint. So we need to build those tools, and we are.
How about Mercy?
Our dignity health, we're retiring those words, Mercy.
Are you? Totally?
You know, the hospitals will maintain the word Mercy, but the rest of the organizations dignity health. You know, one of the things I think we are not integrated delivery system as far as from a the health plan standpoint. We take all health plans and all of that. So from the data standpoint, to really replicate what the learnings are of population health, an enterprise-wide data warehouse project has been embarked with double-digit millions of dollars devoted to it, because we're going to have so many different EMRs from the medical groups, from the hospital systems, to try to get everybody onto one platform was going to be a challenge with the number of hospitals. And at the same time, since we probably got that done, we'd make a change in one of those platforms anyway. So I think this data warehouse project that's coming out of our Phoenix center will be really the large stepping stone. So then you can start layering tools on top of that to be able to use the data. And I think that's what we're all trying to probably replicate the learnings that Kaiser has been able to do. So you really understand, the rest of us, we don't tend to know who our patients are until they cross into either the clinic or into a hospital situation. And I know Hattie gets frustrated when I'll say I have the hospital hat and somebody else is the clinic hat. And that is our reality, is until we start putting us from a population base into a single data warehouse, if you will, we're going to continue behaving like that, I think, excited that it's moving forward. We're a year into the project and probably another year away from. We are going to be doing a heart failure pilot project with the warehouse, I believe in September, October. So, and Sacramento is one of the areas that was chosen to do that. So we'll get a little feel for what kind of meaningful data will come out of that. One of the questions I do have for all of you though is my understanding from the meaningful use requirements that are, we were in the section 2 now, but that meaningful use 3 from CMS will require more population health. And if anybody can speak to that or have information on that, I know I really appreciate that.
I think we can agendize that for a future item. Our expert on that topic just had to leave for a plane, unfortunately. But that's a very good point. Does anybody have that knowledge in the room that I'm unaware of to address the question now?
Another time would be great.
Lisa might have something she can say.
I think that it was the intent is that if you all remember the progression of stage 1 to 3 meaningful use, we're right now where we've collected the data, now we're using it in the sharing phase. And the third phase is really around using that data to improve outcomes. And so that's, where we're going to see the most advanced use of the data is in stage 3. Stage 3 has not been developed. I think they were thinking about pushing that off, that it may be 2017 until we
The unfortunate news is that stage 2 is not being taken out as readily as what was CMS expected. So there's some challenges that I think the message is we need to be a little slower in the requirements. So there's got to be perhaps an assistance to meaningful use to move forward with doing the kinds of things that we need to do. And we've talked at this forum a lot about what would that look like, and one of the things that we've sort of thrown out there is a Sacramento-based HIE as the place to really begin to discuss how we can exchange clinical information much more readily with the existing electronic, because we have fairly significant penetrations now. And as you mentioned, the challenge for Dignity is that there's different kinds of programs out there even within the system. But there certainly is at least a nidus of starting, and I think we've talked about that here, and we could actually benefit the community much more rapidly by really focusing on HIE and its implementation across not just the health systems, but the community pharmacies. We talked about that, and how can we use community pharmacy better? Well, multi-directional or bi-directional information, clinical information that's patient-specific, that is meant to address improving the care of a particular patient, as well as in the skilled nursing facilities, the assisted living facilities, those sorts of things where you could access clinical records and clinical information in a timely way and be able to do the right thing for the patient, other than having to go through multiple firewalls, which currently is a big challenge. So hopefully Right Care might be the place to have that discussion here in the capital region and be able to sort of take a really great stab at beginning the capital-based health information network. But I think that's a great point. Any other sort of ideas around this? And I think we're challenged in Sutter as well in terms of getting the data that we can feel is actionable around the. So the way that it works is that the employers get the basic data first around ethnicity and around other demographic information, and that's passed to the health plan, and then that's passed to the medical groups and the IPAs. And so the better the data is, and this is all voluntary data, by the way, about ethnicity and those sorts of things. So we're really working toward ways to improve that data capture so that it can be much more usable. The other piece, of course, is then the other opportunity is getting that data at the provider level and then improving that data and then going back up the system and then trying to change it so that you don't get the next reel from the health plan. that basically overrides or developing a process so you can use both of that data in a way that is actionable. So that's one of the challenges that we have. And I think we're working more and more with the health plans and, understanding how the importance of getting, and with the employers, because that's where the data really begins. So, I know we're working very hard at that, and I'm sure all the other systems are as well. Lisa?
I just wanted to point out that, the race and ethnicity is required the core measures in stage 1 meaningful use. And so if we're able to capture the information out of the electronic health records, then, we can get that information from the source.
So we had a really wonderful moment here a few months ago with Dr. Alan Schatzel, who heads the stroke program for the Dignity Mercy system. And he talked about how heartbreaking it is for him when he gets a patient in who's had a stroke, but for whom he has no data. And he said that is often, unfortunately, a Kaiser patient, because they're just delivering that patient. And so with most of the health systems in the Sacramento region now using the EPIC program, there is an opportunity to do better clinical information exchange, and it's a matter of convening that effort. I know that Dr. Arevalo has been a big leader in this area, and it's slow going. I think we can all agree this has been our vision for such a long time, but we do have the right people in the room to make it happen. And if we keep pressing it, I think we will definitely make progress. So with that, I think we should say a very big thank you to our speakers and to Dr.
Yeah, next program, August 11th, and I think, Debbie, are you?
Yes, Deborah Odo Kent is our scheduled speaker. We're going to talk about linkages out into community, and Winston, if you want to become a regular participant, that's going to be a big day for learning about that connectivity between the health systems and the community. And we want to thank all of our sponsors and the big idea that's really percolated here about how we can reduce heart attacks, strokes, amputations, and blindness through supporting our health systems with those community-based efforts. So we're really looking forward to your presentation, Deborah. And any of you who need continuing medical education, please see Carla, and she can guide you through that process. We'll see you back here in 1 month. Thank you.